welcome to another episode of Cares Vet Med. I'm Tracy Mahoney, and in this episode, we will be reviewing the two common inhalant anesthetic agents that are used during veterinary anesthesia, and those are isoflurane and sevoflurane. So the anesthetic agents are used to help achieve general anesthesia in our patients. And so the American Academy of Pediatrics states their definition of general anesthesia as a medically controlled state of unconsciousness accompanied by a loss of protective reflexes, including the ability to maintain a patent airway independently and respond purposely to physical stimulation or verbal command. So inhalant agents actually utilize the respiratory system, and then in most practices, they utilize 100% oxygen as the carrier source within the anesthesia circuit. And so oxygen will flow through the vaporizer and deliver a percentage of the inhalant molecules to the anesthesia circuit, and those are as indicated on the vaporizer dial. They also provided dose-dependent effects, including anesthetic depth, which is what our goals are with using the drug, but then also adverse effects include cardiovascular and respiratory depression, and these side effects tend to be more profound than most of our other anesthetic agents. So when we're coming up with a protocol or while we're monitoring our patients during general anesthesia, we sort of always want to use as little inhalant agent as possible. And then the last thing to note for inhalant agents is that they provide no analgesia. While you can have a patient under general anesthesia and in a deep anesthetic plane where they won't respond to any sort of surgical or noxious stimulation, the moment you remove the inhalant agent from their body, they're not going to have that continued analgesia. So you need to make sure if your patient is having some sort of pain in their procedure that you're providing an additional source for analgesia. And so the inhalant agents utilize the respiratory system in order to get the molecules to the central nervous system and brain, where we get this sort of dose-dependent anesthesia effect. And so our inhalant agents will enter into the lungs during inhalation, and then through the process of diffusion, they'll pass from areas of higher pressure or concentration to areas of lower pressure or concentration until equilibrium is achieved. And so the pathway for these molecules is they'll enter into the alveoli, and then they'll pass through a pressure gradient. And since during initial inhalation, there's no molecules within the body, they're going to pass from the alveoli into the arterial blood. And then as they enter into the arterial blood, they're then going to pass through another pressure gradient to the tissue bed, which includes the central nervous system, more importantly, the brain. And then they continue on that transition through another pressure gradient into the venous circulation, and then back to the alveoli and exhaled out. And so once all of these areas are under the same pressure, where we say that the patient has reached equilibrium. And so there's no really major further shift of those molecules that occur at equilibrium. There's also, compared to our other drugs, very minimal drug metabolism. And so other anesthetic agents that we administer via injectable route, they sort of reach a peak plasma level and then undergo some sort of biotransformation within the body. And then they're generally excreted via hepatic or renal metabolism. And then once those drugs, injectable drugs, are excreted, we sort of no longer see the effects of those agents in our patients, whereas inhalant anesthetic agents have very minimal drug metabolism. And so for isoflurane, we see a less than 1% drug metabolism, and then sevoflurane, we see about a 3% drug metabolism, and this is via hepatic metabolism. And then the remainder of the molecules sort of maintain their form. So this is why, in order to have our patients wake up, we have to remove the source of exposure. So we have to turn the vaporizer dial off so that the lungs and alveoli now become the areas of lower pressure, and then the molecules move sort of backwards from the central nervous system and tissues into the circulatory system, and then back into the alveoli, and then exhaled out. So then the next question becomes, well, how long does this process take? Like, how long does it take from the time we expose our patients to our inhalant agents to the time that we then turn the vaporizer off and, have them wake up? And so there's multiple factors to that answer. One of the parts to that is our oxygen flow rate. So when we have higher flow rates, and this is in the process of waking our patients up or when we're trying to get our patients to equilibrium faster, a higher flow rate will help to maintain whatever percentage of inhalant agent, whether that's 1%, 2%, or 0% when we're waking them up. It'll help to dilute out the unwanted percentage and maintain sort of the percentage that you want. So this is when you're talking about the rebreathing circuit. However, it doesn't matter with the non-rebreathing circuit because every breath in is a new breath. So when you want to wake your patient up from general anesthesia with the non-rebreather circuit, turning the vaporizer off, you don't actually have to change your oxygen flow rate because every breath that they take in is going to contain no vaporizer molecule. The other factor is their minute ventilation. And what do I refer to that? Well, a minute ventilation refers to the patient's respiratory rate within a minute as well as their tidal volume, so their breath volume. So oxygen flow rates and minute ventilation will be discussed further in a future episode. So I'm just going to stop there with regards to those concepts. And so the last concept I want to talk about then is the solubility of the inhalant agent. So agents that are more soluble are considered to be a more potent anesthetic agent. And so the determining factor of the inhalant agent's solubility or potency refers to their blood gas partition coefficient. And so the blood gas partition coefficient is the ratio of molecules as a gas in the alveoli and as a liquid in the blood. And equilibrium for both sevoflurane and isoflurane is not a 1-to-1 ratio. So if the molecules were the same number of molecules present as a gas in the alveoli and as a liquid in the blood, their blood gas partition coefficient would be 1. So ratios that are under 1 are referred to as less soluble because more molecules will stay within the alveoli rather than the arterial blood. And then ratios over 1 are considered to be more soluble because more molecules will diffuse into the arterial blood than stay in the alveoli. So for isoflurane, the blood gas partition coefficient is 1.4 in both dogs and cats. So what that means is for every 1 molecule in the alveoli, we have 1.4 times that in the arterial blood. And then sevoflurane, the blood gas partition coefficient is 0.66 in dogs and 0.59 in cats. So that means for every 1 molecule in the alveoli, we have approximately 2/3 of a molecule in the arterial blood. So patients will respond faster to sevoflurane changes, including recovery, than isoflurane because sevoflurane is less soluble and there's less molecules entering into the body outside of the alveoli. So the benefits of using sevoflurane would be in patients that are geriatric or patients that are sick with underlying comorbidities. But if you don't have sevoflurane and you only have isoflurane in your practice, that doesn't mean you can't use isoflurane for sick patients, but it does lead to my next topic, which is discussing minimum alveolar concentrations and ways to reduce the required amount of our inhalant percentage. So MAC, or minimum alveolar concentration, refers to an inhalant's percentage that's on the vaporizer that's required to anesthetize 50% of a given population, in that they will not respond to noxious or painful stimulation. And keep in mind, this is with no additional pre-medications on board, so just exposure to the inhalant agent. So inhalants that are less soluble, they're going to require a higher MAC because the molecules are less wanting to be in the arterial blood and then distributed, to the body. So isoflurane MAC in dogs is 1.3% and in cats is 1.7%. Now sevoflurane's MAC in dogs is 2.3% and in cats is 3%. Now we can take this one step further and increase our 50% population of negative response to 95% of the population to have a negative response if we multiply our MAC by 1.3. So that brings isoflurane only up to 1.7% in dogs, in which we'll have 95% of a population to have a negative response to any noxious stimulation. And then for cats, that's 2.2%. So for those of you in practice that, utilize isoflurane at 2.5%, maybe 3%, in most of those cases, that's a higher anesthetic percentage that you're going to need when these patients are at equilibrium or at their anesthetic maintenance phase. So just a number, to keep in mind at the back of your head, if you find that you're starting your patients at a high isoflurane percentage, you might not need to have them at that high of a percentage. And so then if we're multiplying our MAC for sevoflurane by 1.3, for dogs, that's about 3%. And for cats, that's about 4% on the vaporizer dial. So then we refer to this term called MAC sparing. And so MAC sparing is utilizing a multimodal protocol to reduce the required inhalant percentages for maintaining general anesthesia. So some of those are going to include analgesics or sedatives as like CRIs, or even bolus doses as pre-medication or intraoperatively if they're, responding negatively or they appear to be reacting to surgical stimulation. And then keep in mind, the less inhalant that we use, the faster we can expect our patients to respond to those inhalant changes, which includes recovery. So if you only have access to isoflurane in your practice, using a multimodal approach or a MAC sparing approach to your protocol will make that inhalant agent safer for patients that have those underlying comorbidities or that are a little sicker than our patients that, have no comorbidities present. And so sevoflurane actually, for patients that have hepatic function impairment, including portosystemic shunts, because sevoflurane does have that small amount, that 3% of hepatic metabolism, in my practice, we will utilize isoflurane even in our sick patients that are undergoing, portosystemic shunt attenuation. And then alternatively, if we don't utilize any analgesics or sedatives as CRIs, using agents to increase our heart rate or blood pressure, or both, which will sort of offset the cardiovascular adverse effects from the inhalant agents, and then using ventilatory support, whether it's a mechanical ventilator or another person providing positive pressure ventilation intermittently, that will help to offset the respiratory depressant adverse effects from inhalant agents. So if we have our patients that have received the analgesics appropriately for the procedure, and then during anesthesia, if we aren't utilizing analgesic or sedative CRIs, we can then target drugs that will help to treat the adverse effects that we get from our inhalant agents. And so sometimes we have to do both when our patients are really sick, because any amount of exposure to our inhalant agents really will impact their cardiovascular and respiratory system. So we're picking our drugs to both reduce our inhalant agents, and then we're picking other drugs that are going to help to support the adverse effects from our inhalant agents. There are other factors that will affect our MAC, and so decreases in MAC aside from our analgesics or sedatives are also going to include hypothermia, hypoxemia, geriatric, which I had mentioned, pregnancy, hypotension, and then hypothyroidism. And then increases for our MAC are going to be patients that are hyperthyroid or have increases in catecholamine. So if they're stressed, if they have, adrenergic secreting tumors such as, pheochromocytomas, and then some drugs such as ketamine, for example, hyperthermia, and then hypernatremia. So the last item I want to review in this episode before we get to our CARES action is talking about personnel precautions. Workers that are exposed to our inhalant agents have reported episodes of dizziness and headaches. And then in laboratory animals that were exposed to repeat doses of inhalant agents. They noted these patients to develop nerve cell damage. They had learning and memory impairment, as well as behavioral changes. There was a note in the reduction of sperm production and function, as well as infertility issues for females. So in practice, the goal is to always reduce staph exposure. And so the ways in which we can do that is we can always make sure we turn off the gas flow when we're disconnecting the patients from the anesthesia machine, for example, when we have to reposition them or flip them. And what I mean by turning off gas flow, I'm not talking about the vaporizer, I'm talking about your oxygen flow rate. So when your oxygen flow rate is on, you're having an influx of volume to the circuit. So if you remove the influx of volume to the circuit by turning off your flow meter, you'll be able to reduce the amount of gas that comes out of that breathing hose when you disconnect your patient. And then always making sure before you use your anesthesia machine for any patient that you're leak checking the machine before each case, okay? And also making sure that you're keeping up with any sort of annual maintenance and servicing. And so for our practice in Connecticut, we have a company that comes in once a year and does maintenance and servicing on all of our anesthesia circuits. The other thing to help reduce staph exposure is making sure that your patient is connected to the anesthesia machine during the initial recovery. Again, so that inflow of oxygen is helping to dilute out that expired inhalant molecule, and then it also is containing that exhaled breath to the anesthesia circuit and preventing it from going into the environment for staph exposure. And then if you have a passive scavenge or the F-air canister, some sort of charcoal-based canister, you want to closely monitor that weight and then toss it once that maximum weight gain has been achieved. The other thing is during general anesthesia, you want to make sure that your endotracheal tube cuff is sealed. And the capnography, if you have access to capnography, that waveform can be a really helpful tool in that it'll detect a leak on the patient side of the capnometer. It won't detect any leaks within the anesthesia machine, though. It just will tell you if there's a leak present on the patient. And so anything from the endotracheal tube into the patient, if there's a leak present, then you'll notice that on the capnography waveform. And then trying to avoid usage of face masks to maintain general anesthesia, because despite the goal of it being tight fitting, you're always going to have a little bit of leaking around the mask. And then I just want to make a side note here, because I do not recommend at any point using mask for induction and or maintenance. And the reason for that is, again, going back to our definition of general anesthesia. So mask induction and or maintenance, it does increase the staph exposure to the inhalant agents, but it also, when we get our patients to that goal of general anesthesia, they have a loss of their protective reflexes, which includes their ability to sort of close off their larynx or swallow in the presence of any fluid in the back of their throat. And so this really is going to increase their risk for aspiration, especially if the patient's airway is not intubated and secured. And so that concludes our episode on passing gas. And at this point, I want to review the CARES action for this episode, and that's going to be benefit of the doubt. And what I mean by that is, if you ever are in a situation or circumstance where you're interacting with someone that might be a little bit abrasive, or maybe they're a little angry or irate, and they're just not being kind, instead of coming back at them with that same sort of energy, taking a moment to just say, you know what? I don't know the circumstances they're going through. Maybe it's an irate client that has to say goodbye to their pet, or has to make a decision that's very difficult for them regarding their pet and their pet's health. Maybe it's a coworker that has had a few bad cases, or just has a lot going on outside of work, even, or maybe a family member that's just has a lot on their mind, has a lot going on, and maybe aren't responding in the best way that they could. Instead of being defensive, abrasive, and sort of giving that back to them, just, remember to give them the benefit of the doubt and just respond in kindness, respond in compassion and empathy, saying, I'm sorry, things are tough. I'm here for you. Talk to me if you need anything. I understand what you're going through. I'm sorry that you're going through this, to a client, saying, I'm so sorry that you're having to make this difficult decision. I understand that frustration. I understand that stress. I'm here for you. Sometimes we can be kinder And that can make a huge difference and really turn a conversation around. I've seen it a lot of times in my years of practice, and a lot of people do it better than I do. But it is good to, in moments that seem to be escalating, and just taking that moment to being and showing a little more kindness rather than abrasiveness, you might positively impact that other person's day, which again is sort of, the goal of the CARES action is just showing kindness in the face of unkindness. And that's a wrap. Thank you so much for listening in on this episode. I hope there was information that was reviewed that's helpful for you in your practice. If you have any feedback or suggestions for this episode or for future episodes, if you want to join me on a future episode and talk about something anesthesia, or even veterinary medicine related in general, that you're passionate about, I'd love to hear from you. You can email me at caresvetmed@gmail.com, or you can connect on Facebook, Twitter, Instagram, TikTok, and YouTube, and that's at caresvetmed. This podcast episode is available through Apple Podcast, Amazon Music, and Spotify. And lastly, thank you. Thank you for all that you do out there for the furry patients and their families. I see you and I appreciate you. Take care, friends.